Hello everyone, and welcome to the 55th seminar presented by the Centre of Research Excellence in Aphasia Recovery and Rehabilitation. My name is Dr. Rebecca Sullivan. I'm a postdoctoral researcher with the Speech Pathology Department at La Trobe University and the Aphasia CRE, and I'm co-facilitator of the CRE seminars along with Dr. John Pearce. Firstly, I would like to acknowledge the traditional owners of the land on which we live and work across Australia. So I'm speaking to you from the land of the Wurundjeri people of the Kulin Nation, and I pay my respects to elders past, present and emerging, and extend our respect to any Aboriginal and Torres Strait Islander people here today. Today we're hearing from Dr. Leora Cherney and Laura Kinsey about measuring real-world communication of people with aphasia, preliminary findings and ethical considerations. So just a reminder to please submit your questions using the Q&A feature in the Zoom toolbar at the bottom of your screen. And if you can avoid using the chat, that would be great. You're welcome to submit questions at any point during the presentation. This feature will allow other participants to like the questions they're most interested in. I'll prioritise the most popular ones when we have time at the end for the Q&A. So please keep your questions brief and focused and avoid submitting general comments. We do have some time at the end of the talk to address as many questions as we can. So it's my pleasure now to introduce today's guest speakers, Dr. Leora Cherney and Laura Kinsey. Leora is the Scientific Chair of Think and Speak and founder and director of the Centre for Aphasia Research and Treatment at the Shirley Ryan AbilityLab, which was formerly the Rehabilitation Institute of Chicago. She's also a professor of both physical medicine and rehabilitation and communication sciences and disorders at Northwestern University. Leora has 40 years of clinical and research experience in the area of adult neurological communication disorders with a specific emphasis on aphasia. Her cutting-edge research has explored behavioural, pharmacological and neuromodularity interventions. It includes both single-subject research studies and randomised clinical trials and measures of outcomes relative to both impairment and participation levels. She has a continuous record as a PI on federal, private and industry-sponsored research grants. She's received numerous prestigious awards, including honours of the Association from the American Speech Language Hearing Association, the Illinois Speech Language Hearing Association, and the Academy of Neurological Communication Disorders and Sciences. Leora is also a fellow of the ACRM and recipient of the ACRM's Women in Rehabilitation Sciences Award. Dr. Cherney has co-authored 5 books, has over 120 peer-reviewed journal articles, and regularly presents at workshops and conferences nationally. Laura Kinsey is a research speech-language pathologist at the Centre for Aphasia Research and Treatment at the Shirley Ryan AbilityLab. She works clinically in a comprehensive day rehabilitation setting with adults with acquired neurological disorders prior to transitioning to her current role in aphasia research. Laura works primarily as a clinician delivering behavioural interventions for various clinical trials. She has published preliminary findings of the content you'll hear in today's talk regarding measuring real-world communication of people with aphasia, as well as texting behaviours of people with aphasia, modality effects of handwriting versus texting, and ethical considerations of patient autonomy in right hemisphere dysfunction. Laura's primary interests include leveraging technology to support individuals with aphasia, advocating for communication accessibility in the context of research participation and community engagement, and incorporating participant experiences and feedback into the research process. Laura also has participated in a 2-year bioethics program that gave her a newfound interest for considering ethical dilemmas across the research continuum, particularly when it comes to research accessibility, informed consent, and data collection and dissemination of research findings. So it gives me great pleasure to introduce them to you now.
Thanks, Rebecca, for that introduction. And Laura's going to pull up the slides. And here you can see again what we'll be talking about, and just wanted to emphasize that this is preliminary findings and ethical considerations, and we'll be addressing both of those. So we can go to the next slide. Financial disclosures. We are full-time salaried employees at the Shirley Ryan AbilityLab, and the work that we are presenting today was federally funded by the National Institutes of Health, which is our U.S. Federal funding agency, and we have no relevant non-financial relationships to disclose. Okay, so this is a little bit about our agenda. I'm going to start out by talking about how the wearable devices that we're going to be highlighting today fits within the context of a larger randomized controlled trial. And then Laura will take over and she'll talk about the methods and results and lessons that we've learned from using the wearable devices. She'll then go on and discuss the ethical considerations that we have identified using these devices in the real world, and also share preliminary feedback about collecting real-world data with persons with aphasia as we move forward. So again, this is one piece of a randomized clinical trial. So I'm going to tell you a little bit about the trial that this is kind of embedded within. And the randomized clinical trial really focuses on script training. And I'm going to assume that most of you do know what script training is. But just in case, a script is a sequence of sentences that a person typically speaks in routine communication situations. And we use scripts all the time. When we're ordering pizza over the phone, as an example, we will routinely indicate what kind of pizza we want, what the size of the pizza is. We might ask how much it costs. We might give our address for delivery. So that would be a typical script. Making a doctor's appointment is a script. A job interview could be a script. And with script training, what our goal is for the person with aphasia to practice the phrases and sentences so that they become automatic and easy to produce. And then these islands of automatic speech could then be used in real life situations. The rationale behind script training is really based on something called the instance theory of automatization. And the idea is that repeated exposures to each phrase or sentence gives a lot of practice. And that practice of the phrases and sentences, when it's done in the context of the entire script, can help make production of the phrases and sentences effortless, fast, and automatic, so that after all of this intensive practice, the person can use these islands of communication in the real world. So we'll go to our next slide. So in this randomized controlled trial of script training, we were investigating the factors that modulate dose and intensity of script training. And there are two factors particularly that we were interested in. Participants received 10 one-hour sessions, and they were randomized to either receive the treatment 5 days a week for 2 weeks, or 2 days a week for 5 weeks. So with that, we were looking at the difference between intensive versus more distributed practice. And then the other aspect that we were looking at was stimulus repetition. So participants were randomized to either have a 5-sentence script or a 10-sentence script. With a 5-sentence script, they were getting more practice on fewer items. With a 10-sentence script, they were getting less practice on more items. So we were looking at how much practice is needed and how much repetition is needed within therapy in order to get this automatization of the script training that they could then use in conversation. Our outcomes were generalization to conversation. And I want to highlight here the importance of what we were measuring was generalization. We were not measuring the participants' communication responses during training, but we wanted to look at generalization when they produced the script, as an example, with a speech and language pathologist, or in an unscripted conversation with a novel communication partner who they've never met before. In addition, we wanted to know about their conversational skills in the real world when they were at home or in the community. And so that's where our wearable technology has come into play, but more of that in a little while. Laura will address that in a little while. I want to tell you a little bit more about the script training that we did. We actually used a virtual clinician that delivered the treatment. So we have a program called Aphasia Scripts, and we modified this Aphasia Scripts program to deliver the treatment. Because we were using the computer-based treatment, this really ensures treatment fidelity. So every participant then received the exact same treatment without differences occurring because the therapy is given by different therapists, or even the same therapist but in a different way. During therapy, you can see the top picture there. During therapy, the person would listen to the script once, then they would do sentence practice for 25 minutes, followed by 5 minutes of practicing the script. And then again, they would do 25 minutes of sentence practice, followed by 5 minutes of practicing the script. So they went backwards and forwards between the conversation practice and the sentence practice, but it was the sentence practice, which is where most of the practice occurred. During the sentence practice, we can go back one slide still. During the sentence practice, a lot of repetition would happen. They were told, first of all, to look and listen to the sentence. And while that was happening, the avatar, the virtual therapist, would read aloud, and each word would light up as they were reading, as they were listening to that sentence. Then they were asked to point to each word again as the virtual therapist read the sentence again. Then they did choral reading of the sentence, and they did this twice. Then they would attempt to do independent reading one time of the sentence. Then they'd go back to doing choral reading again. And then they would move to the next sentence of the script. But you can see there were multiple opportunities to practice the script, again, to get this automatization or fluency of the script. I also just wanted to mention that our original plan for the study was that this was going to be an in-person study. Then, of course, COVID hit, and we had to modify the study, and we had to reconfigure things so that it could all be done virtually. And so we were able to recruit many subjects across the country once we went virtual, but it did take quite a lot of effort to ensure that we were able to conduct the study virtually. Okay, so now that you know what the study actually was about, I want to give you a little bit of background about the wearable technologies. And I need to give a shout out to our Australian colleagues who are responsible for really coining the concept of talk time. This idea was based on the idea of steps being logged by a pedometer as a gross indicator of physical fitness. And the authors, the Australian authors, suggested that similar to a pedometer and the number of steps that are taken, talk time may be an indication of communicative fitness or communication participation. They did acknowledge that these indicators are not perfect. For example, when you think about physical activity recorded by a pedometer, there's stepping that happens, but this doesn't consider other exercise activities such as cycling or lifting weights. So similarly, talk time does not include other forms of communication like writing or reading, but it does include verbal communication. So this was really an important concept in terms of measuring real world participation, and it's really an attractive concept. So to record talking time, what the Australians did is they developed a smartphone application that they called Comfort. And this application, this app was then paired with a Bluetooth headset. And the Bluetooth headset registered sound, but it did not register speech. The speech was not actually being recorded. So that did so in that way, there was some privacy that was protected. And so again, the headphones, the Bluetooth app was measuring talk time, but not really the language and words that were being used. One of the issues, though, there were several technological issues with the Comfort app. One of the big issues was there was background noise interference. So sometimes the speech was not differentiated from background noise, or differentiating between speech and background was difficult. There was also difficulty differentiating who was the recorded speakers. So if there were multiple speakers, it was sometimes recording the non-aphasic person or somebody else in the room. There were also issues with operating Bluetooth applications, and there were some issues with short battery life. So, so we have developed, we were able to use with some engineering developers a different kind of approach in terms of looking at talk time in the community. And so I'm going to hand this over to Leora now, who will talk about the wearable devices that we've been using and the study that we have done and what our findings are. And then, of course, the ethical aspects of it. So Leora, handing it over to you.
Thank you, Leora. And thank you to the Center for Research Excellence in Aphasia Recovery and Rehabilitation for inviting us to share this information with you. So what I'll do now, as Leora said, is go into the specifics of this pilot study using the wearable devices. And I'll first off share some of our methods for collecting this data. And then I'll go into, again, some of the preliminary results and some lessons we learned along the way. So when we set out to measure real-world communication, we narrowed in on a few research questions that would help us to better understand what's already happening at baseline. And we needed this background context before being able to really make any claims about the treatment generalization. So to do this broadly, we wanted to know, one, how much and where people with aphasia talk in the real world, and what may influence their communication behavior, and also if this was even possible to do this kind of measurement. So to collect this data, we piloted the use of these three wearable devices. On the left here, first, you'll see a laryngeal sensor. And this again was designed by our biomedical engineering colleagues. And the sensor was configured to detect laryngeal movements associated with speaking. And in fact, it could differentiate speaking from other laryngeal movements, such as coughing or swallowing. So pretty cool. So for our purposes, this offered an objective measure of an individual's talk time. Next, we gave participants a GPS tracker shown here, which is pretty self-explanatory. And lastly, we gave them a small audio recorder or microphone that was clipped to their shirt and would record the participants' conversations throughout the day. So if participants consented to using these devices, they were asked to wear them at 3 time points during the larger RCT, at baseline, post-treatment, and at the 6-week follow-up time point. We asked participants to wear the devices for 3 days at each time point for 8 hours each day. I'm also going to make a quick note here that the preliminary results that we'll share today only discuss those first 2 devices, the sensor and the GPS tracker. We're still going through some audio recorder data. As you can imagine, there's a lot there, but we will revisit the audio recorder later in this presentation because we're going to delve into some ethical dilemmas that surface with data collection, and we will spend a little more time there. So for this talk, we're going to report on our first 16 participants. We had 3 females, 13 males. Racially, all participants were white, with 2 individuals also identifying as ethnically Hispanic. And so I will quickly identify that the lack of diversity in this sample is a limitation that we recognize up front. In terms of age, the majority of our participants, 9 of them, fell in that 46 to 64 category, while 4 participants were on the younger end, 26 to 45, 2 participants aged 65 to 75, and 1 participant over the age of 76. So using the fluency score from the Western Aphasia Battery, coupled with clinical judgment, we had 5 participants with fluent aphasia and 11 with non-fluent aphasia. And again, using that WOB criteria, the majority of our participants' aphasia was classified as moderate, while 5 individuals had mild aphasia and 1 individual had severe aphasia. In the bar chart on the right here, you can see a breakdown of years post-onset on the x-axis and the number of participants in each range here on the y-axis. So just looking at this distribution, you can see some individuals acquired their aphasia more recently within the last few years, and some had been living with aphasia for many years. So now getting into our preliminary results. Again, our main question going into this was, how much do people with aphasia talk in the real world? And what we found was, on average, participants talked for 56.5 seconds per hour, less than a minute. And there was a range. So the standard deviation here was about 35 seconds. But again, this seems to be a very limited amount of talking. So this is a little bit of a busy table here, so let me orient everyone. This table shows our baseline data for 16 participants. You can see in column 1 across their 3 days using the wearable devices. The TT column in orange shows an individual's average talk time per hour in seconds. And in the purple column, GPS, this shows the number of distinct GPS locations an individual was tracked at each day. Home was considered one location. So for example, if you see a 1, that essentially indicates the person didn't leave their home that day. So there's a lot of details here, but I just wanted to kind of display this table for you momentarily to just illustrate that there is variability among the participants. So coming back to these original research questions, we were able to answer some of these with the quantitative data we collected. The first was looking to see if there was a relationship between mean talk time and aphasia severity or fluency. And what we found was no relationship between the severity of someone's aphasia and their mean talk time, which was kind of surprising. We assumed that maybe those with severe aphasia might log less talk time than those with the more mild aphasia. That wasn't necessarily the case. We did, however, find a positive relationship between fluency and talk time, with individuals with fluent aphasia on average talking more. We were also curious to know if there would be any relationship between someone's communication confidence and their mean talk time or the number of GPS locations they tracked. So to analyze this, we used self-ratings from the Communication Confidence Rating Scale for Aphasia, the CCRSA, and found the answer to be no to both, indicating that those with more confidence didn't necessarily talk more or travel to more locations than those feeling less confident in their communication. And lastly, we were curious about any relationships that surfaced between GPS locations tracked and mean talk time and aphasia severity or fluency. And what we found was that there was no relationship between GPS locations and mean talk time or aphasia severity. But there was a positive relationship between GPS locations tracked and aphasia fluency. So again, those with more fluent aphasia on average logged more locations in the community than those with non-fluent aphasia. We hypothesized that individuals with fluent aphasia may be less inclined to have a physical disability as a result of their stroke, which may influence this finding. But that's, again, only a hypothesis. We also know there are so many variables that factor into communication behaviors, even for those of us without aphasia. So to contextualize this data a bit more, we looked at some psychosocial, physical disability, and environmental characteristics of participants to paint a fuller picture. This is a non-exhaustive list, but I'll talk through some of the factors we looked at. The first being someone's living situation. So knowing if there were others in the home felt relevant to talk time. In this sample, only one participant lived alone, while the other 15 lived with at least one other individual, if not more. Mental health is also a significant contributor to our desire and ability to connect with others. So we administered the CESD, the Revised Center for Epidemiologic Studies Depression Scale, a self-report measure to detect depression. And all but one participant endorsed minimal or no significant depression, with one individual endorsing symptoms of a more mild to moderate depression. Although it was not an explicit aim of this study, we found no relationship between self-reported scores on this measure and mean talk time or GPS locations tracked. Next, the presence of a physical disability has the possibility to be a barrier to engagement outside the home, and we consider this as a factor for talk time and GPS locations. And while there was no relationship in our sample, I do want to mention we had a relatively mobile sample compared to the stroke population at large. As you can see here, all participants were able to walk in some capacity, while only a handful used an assistive device like a cane or walker for ambulation. We also know that an individual's driving status or access to transportation may influence communication and engagement. So again, results here were sort of mixed. Most of our participants were either driving or able to drive and use public transit independently, while we had 6 participants who were completely dependent on others for their transportation outside the home. And lastly, we were curious about regional access, for example, urban versus rural, to better understand if there may have been any barriers to communication behaviors based on this. And again, a handful of participants in our study resided in a large central metro area. For our Australian audience, I'm thinking Sydney, for example, while most of our participants lived in more medium metro regions, think Canberra or Newcastle. And then we did have a few participants that lived in more rural, kind of isolated regions. And then coming back to our second research question here, another big piece of this puzzle was to look at feasibility. Is it even possible to measure real-world communication? And the short answer is yes. We had a high compliance rate amongst participants using these 2 devices, so the laryngeal sensor and the GPS tracker. And people with aphasia rated the acceptability of the devices rather high in terms of comfort, the ease of application, and the ease of setup and takedown. So this is good news. So some final takeaways from our lessons learned while collecting this data are noted here and expanded in the subsequent publication that I'll share here on the next slide. But as Leora mentioned, the physical impairment, we were conducting this study virtually. So we had to think of ways that we could set the participant up with the devices to be successful, particularly in the presence of a hemiparesis. So doing what we could to prepare the devices, think about which devices we were choosing, and again, making sure they were able to be used. The accessibility of how we provided the instructions and adapted them to meet the individual's needs. For some people, having printed communicationally accessible instructions was sufficient. For other people, we actually had to use sort of a dock camera and demonstrate how to use the devices. So sort of meeting people where they were. Adapting our procedures was huge, not only for the remote virtual nature of the study, but also just how we were training participants to use the devices and how often we were checking in with them to make sure they were set up correctly, that people didn't have any questions throughout the recording period. As we've all experienced in the virtual age, technology malfunctions are imminent, and we had to kind of decide what was within or with outside our control and do some creative problem solving, especially at a distance. Familiarity with technology, again, meeting people where they were and trying to provide additional support to those who may have been less familiar. Identifying a local point person or partner who was in the same physical proximity as the participant was super helpful in the case that we were unable to problem solve with the participant on Zoom. When I mentioned context matters, sort of talking about some of those more broad pieces of data that helped us paint a more comprehensive picture of how to interpret some of these findings, we did a lot of that retrospectively, kind of going back and asking people about that information. And for anyone looking to do this kind of research, just planning ahead, thinking about what kinds of questions to ask, what types of demographic information to collect, more on the front end, so you're not doing as much digging on the back end. And then partnership was huge for this study. This type of data collection requires a lot of trust and collaboration. It's new for the participants, it's new for us. So there was lots of learning on all sides. So be flexible and creative was a huge takeaway for us. So I'll just quickly reference, this is the publication we had submitted last year. And if you'd like to read further about some of our findings, I'll just, again, drop that here. And then for the second portion of the talk, I'm going to transition to the ethical dimensions of collecting data of this nature that kind of surface throughout the study.
Laura, before you do that, I'm wondering if I could answer one of the questions that I see in the chat.
Yeah,
So
absolutely.
yeah. So the one question is asking about how this compares to how much non-aphasic people speak. And I just wanted to mention that we did not have a control group of non-aphasic speakers. What our plan was to look at how this was going to change over time from pre-treatment to post-treatment. But I just wanted to mention the Brandenburg study did have 12 people with non-fluent aphasia and 7 people that were non-aphasic. And they did find that there wasn't a significant difference, but the people with aphasia did speak much less than the people who did not have aphasia. Their numbers were a little bit higher than the numbers we found. They found that non-fluent aphasics were speaking about 4.5 minutes per hour. Also very, very little. I mean, we were less than a minute, but this was very little, 4.5 minutes per hour. Whereas the healthy non-aphasic patients non-aphasic individuals were speaking about 7.2 minutes per hour. So just thought that we could just answer that question real quickly. And other questions we'll answer at the end. Thank you. Sorry to interrupt.
No, thank you. Thank you. So pivoting here to some of the ethical dimensions, we initially set out to collect this body of evidence that could contribute more robustly to our understanding of living with aphasia and communicating in the real world. But as data collection progressed, some ethical tensions were surfacing that kind of gave us pause as researchers. And we found that those tensions often lied in striking a balance between participant autonomy and data quality and completeness. I'll give you some kind of concrete examples here. One panicked care partner called me, nervous that her husband, who was the person with aphasia who was using the devices, had walked in on her in the shower, and she was concerned that this laryngeal sensor recorded video. And it didn't, but that sort of gave us information about how he understood the functionality of the devices, not only what they do, but what they do not do. Was he fully informed? We didn't feel confident he was. We also had people ask questions about what if I need to have a private conversation? Do I turn the device off? Do I leave it on and place it in another room? And as researchers, we had concerns. If the devices were turned off, would they be turned back on? Would they be time stamped so that we would know sort of how much of the conversation was cut? And obviously, giving people the autonomy over their private conversations is paramount. But we were trying to figure out sort of what we could do to, again, sort of meet the needs of both parties. We had people ask, what if I in the moment don't anticipate something private coming up, but then later I sort of think back and I want something deleted. As researchers, we would still need to potentially listen to the recording to identify that segment of time. And would we have the precision to be able to delete exactly what it was the participant wanted? Would we have the capacity to do that kind of alteration? And then we had a lot of questions about who is recorded, because the microphone itself, for example, had a 15-foot radius. So while the participant was recorded best, it's possible that others were picked up. And so we had these questions about who do we consent? So there was a lot of push and pull that kind of required us to think more about our practices and identify more clearly some of these negotiations or improvements that we could make. So for those of us doing human subjects research, or for any of us in any clinical position, we practice under these sort of core pillars of bioethics. And when we're dealing with these novel technologies, there's a more contemporary principle that's been proposed. That is explicability, or doing our due diligence to ensure we've been transparent and thorough in our explanation of what these technologies do and how they work. And as we know, so much care and intention already goes into the informed consent of individuals with aphasia to ensure that a study has been explained thoroughly and in an accessible way. So these novel technologies just sort of take this one step further. And before I go on to the next slide here, I have to give a shout out to my colleague, Alyssa Larkin. She's a formally trained speech language pathologist and bioethicist, and she helped influence and inform a lot of these conversations that we'll have. And this slide in particular, I stole from her. So I wanted to give her a shout out. So we applied for and were awarded an NIH Special Interest Administrative Supplement that allowed us to look at bioethical dimensions of our research and to give us the funding and subsequently the time to narrowly review our practices and identify these tensions. So the first thing we developed was a pre and post training survey regarding use of these wearable devices. And we implemented this at the baseline of the RCT, so when participants were learning to use the devices for the first time. I'll talk about this more here on the next slide. But then we conducted semi-structured interviews with participants and their care partners regarding their experiences and opinions using the devices. And we made the intentional decision to elicit this feedback at the post-treatment time point so that participants had now had a couple opportunities to use and wear the devices, and we thought they may have more familiarity and just more robust experiences to share. And lastly, we hosted an interdisciplinary ethics summit, which again, I'll talk more about in future slides, but this offered us an opportunity to explore some of these considerations from more of a multidimensional perspective, ensuring more diverse voices were represented and not just our study team influencing or biasing the decisions we were making. So again, this pre and post training survey we did at the baseline time point. The participants had no familiarity with the devices. They just had them in front of them and they were about to use them for the first time. So we conducted this session via Zoom. We were able to do this survey with 9 participants with aphasia. And just of note, 6 care partners or 6 of those sessions included care partners that were present for the duration of the session. We asked around 4 to 5 questions in Likert scale and sort of open-ended format. And some of the themes we'll explore here on the next slide. So kind of the reason to implement this survey gave us a chance to explicitly make the space to discuss these devices and offer participants a chance to kind of sit and reflect on their relationship to these devices. We never necessarily expected them to rate their understanding as 100% or 10 out of 10 of all aspects of the ins and outs of each of the devices, but just to more explore areas that still felt sort of uncertain or unfamiliar. We wanted to get to a place where participants and care partners felt good enough or confident enough to use, to continue to want to use the devices. So explicability was something we probed a bit. So pre-training is the light blue here and post-training is the dark blue. And so our question was, has our team explained the devices to you in a way you could understand? So before the training, the average rating was about 6.4. After the training, the explicability rating went up to 8.9. So this is good news. We want people to feel like they're understanding, and we've explained in a way that's more informative. So a lot of questions that kind of came up during the training were more logistical. Do I carry the phone with me all day, for example? How do I charge the sensor? What does the green button on the GPS tracker mean versus the red button? Questions about the microphone and the recording. And we also asked about the rationale. How well do you understand the reason for using these devices? And again, we had an average rating of 6.7, and after the training and sort of explaining each of the devices more thoroughly, we saw that number jump to 8.8. One of the questions, for example, that came up is, why do you need to know where I am during the day? And so this kind of, again, let us explore some of these questions with the participants. Another question we asked, how confident do you feel setting up the devices? On average, people said about 5.3 beforehand, which would maybe make sense given that they'd never used them before. And after training, the score went up to 8.3. So a lot of people felt they just needed practice, repeated opportunities to sort of use and feel more comfortable with doing this independently. I also really like this quote that's sort of illustrative of that. I had said, are you feeling better about the devices than you did 20 minutes ago or about the same? And the participant said, yeah, because it's a little different, but I know it's fine, but everything is good. Yeah, okay. And I said, like, it's just kind of an adjustment or yes, kind of weird and new. The participant said, exactly. Once the participants sort of had the devices on and they were geared up and ready to go for the day, we asked them, how do you feel now about wearing the devices? At home, people felt relatively positive. They said, it's fine, not a big deal. One person even said they were excited, which is great. But when we asked how you feel about wearing these out in the community, the results were a little bit more mixed. One person indicated they felt sort of more self-conscious about having the devices on, and one person said, really none of these feelings. It is really indicative of how I feel. I'm more worried about how others in the community will feel, maybe being recorded. So that was really important for us to know. So again, at that post-treatment time point, they've used the devices a couple times now. We wanted to interview them and get their experience. And so we conducted these interviews via Zoom, and this was with a different speech language pathologist who was not responsible for conducting the training, who could sort of ask these questions in maybe a less biased or less just sort of being removed from the situation so that participants could maybe open up more freely about their experiences. So we were able to conduct 20 interviews, 11 per persons with aphasia and 9 care partners. And again, we asked these questions in Likert scale and kind of yes/no format. And we had people often do their rating on a Likert scale and then elaborate on why they rated something that way through some supported discussion. And then some of the themes included the device functions, communication and consent practices, control over data, risks, benefits, and privacy and confidentiality. So this, for example, is kind of what that discussion guide looked like. And we included some pictures and icons here to sort of support the individual's ability to participate in this interview. So one of the questions we asked was about informedness. Was information about the devices presented in a way that you or the person with aphasia could understand? And on the left here, the light blue, participants' average rating again was 8.2, care partners 8.3, so about the same. And how informed were you about the purpose of the devices? Here, care partners actually rated themselves a bit higher than our participants. And kind of going back to what I mentioned earlier, we may never expect these ratings to be 100% or 10 out of 10. But this again kind of gave our team some context as to where participants or care partners identified some weaknesses or sort of murky areas that our team could hopefully improve on. Control over data. How much control do you feel you had over what data was being collected and when? So again, we kind of getting at that autonomy piece, which was often, again, in tension with our aims to collect this robust and complete data. And so, for example, if we gave participants control over the audio recording and turning the microphone on and off at whim, that meant we may lose some or all of the audio data. And then for the when piece, because we were often operating within the study team's schedule of Monday through Friday, 9 to 5, give or take, we had the participants sort of collecting the data on a schedule that maybe benefited our team or that was feasible within our team's capacity. And in terms of consistency, we wanted to catch people on the same kinds of days before and after the therapy. So if we had them record on a Monday, Wednesday, Friday at baseline, and those were pretty typical days for them, we maybe wanted to have them do Monday, Wednesday, Friday at the post-treatment time point so that we could say that those days were consistent and typical and comparable. And occasionally, sometimes, that was at odds, the team schedule versus the participant schedule. We also asked how informed people felt about the risks of using the devices. Interestingly, the care partners actually felt a little more informed than the participants with aphasia. And when we looked at confidentiality and privacy, this first one here with confidentiality, this was a pretty high rating. So both participants and care partners felt that the research process would protect their confidentiality. And this the middle graph, we have to what extent do you feel the process considered the privacy of the person with aphasia? Again, care partners rated slightly higher, but on average, pretty high. And then this was good information for us. So this was asking about the privacy of others. And actually what people expressed to us was that we maybe didn't necessarily consider the privacy of others as much as we considered the participants. So this was something for us to consider. So some interview conclusions we'll walk away with here. Elicit feedback and do it regularly. Oftentimes at the end of a study, we'll elicit feedback and say, how did that go? This was not that kind of study. We needed to do that feedback ongoing and collecting feedback from all members, not just participants, but also their care partners and study personnel. This was innovative and we were all learning together. We needed to hear how it was going for everyone on the team. Identifying and involving the village. So again, because care partners are so ingrained in the collection of this real world data, it was really helpful, we found, for the care partner to be present for the consent session and or the training session, if at all possible. Again, not only to be support for the participant to help them make that shared kind of decision, whether or not to participate, but also because they might be incidentally recorded by some of the devices. And then I also want to mention supporting autonomy and decision making. One thing our team learned is that it's not enough to sort of identify and answer these questions as they come up, but to be more intentional about creating space for people to share their questions or make these choices when they're using the devices and at these different time points, again, rather than just kind of saying at the very beginning, here are all of your options in these various scenarios. We need to provide that explicit education and doing so ongoing. So we can establish all the procedures and protocols we can at the front end, but providing that dynamic choice, knowing that that initial consent session might not be sufficient, we might have to continue to have these conversations over the course of the study. I'm going to pivot now to talk a little bit about our interdisciplinary summit. We wanted to bring together, again, a diverse group of people here. We had a participant with aphasia who used the devices. We had colleagues who worked in rehabilitation and research medical or mechanical engineering. We had our compliance team from Shirley Ryan, our team of research SLPs, some in-house and external bioethicists, our legal colleagues, our institutional review board or our regulatory representatives to chime in, and a care partner join this summit so that we could discuss these items more robustly. And while we're still analyzing some of those transcripts from the summit, which was a full day event, which was so rich and so thought-provoking, we do have a few key takeaways that we want to share with you today. One is that it was really encouraging and positive for us to hear that our institutional review board actually supports this kind of ongoing consent practice. And they were very supportive of the idea of these adaptive and accessible accommodations for people with aphasia, especially when they're implemented properly by trained research experts. And something we needed to sort of check ourselves on and check our biases is not being paternalistic or making decisions or speaking on behalf of our participants with aphasia, but actually doing more encouraging shared learning and decision making together versus, we know what's best. Another piece we learned is know the laws. Here in the US, there are actually state by state differences in the laws of recording in public spaces, which was very interesting and very good to learn from our legal colleagues. And then just a final piece here about standards, that this is kind of something we should always operate by. Legal is the floor, ethics is the ceiling, and we're always going for somewhere in between. So the next steps of this study are to review and analyze the changes in talk time from pre to post intervention at the 6-week follow-up, to analyze the content from the audio recordings, and to hopefully develop some best practice recommendations to inform the use of wearable technologies with people with aphasia, and again, using that input from a diverse body of vested parties. We've got a few additional readings here. So we've linked our publication from the American Journal of Speech Language Pathology. We have the ComFit paper here that Leora referenced earlier. So I encourage you to take a look at that. And then if you're really into mechanical engineering and you want to know more about the sensor and how it works, this is a more engineering type paper, but we've linked this here as well. And nothing happens in a vacuum. This takes a village, and I'm very grateful for our village. These are all of the people who made this work happen. And so I just want to acknowledge them and thank them. And lastly, I'll leave our thank you and then my contact information and Leora's contact information if you have any questions, comments, or want to connect with us about anything else.
Thank you. That was fantastic. We actually do have a few questions, so I'll just run through them. Okay, so the first one is from Emma. I'm wondering if the stats around mood difficulties in people with aphasia, if the group of participants that you had was less represented, which might have impacted your results in any way?
Do you want me to take this one, Leora?
Yeah, go ahead. That's fine. Yeah,
Okay.
go ahead.
Yeah, I think, again, this was very preliminary, very small sample size. And the fact that 15 out of 16 participants didn't identify any clinical symptoms of depression does not speak to what we know from the literature in this population. So I absolutely think more research is needed with a much broader sample that, again, would be more representative. And I'm very curious to know how that would influence the communication behaviors we found. So yes, I think that's a great question.
Yeah. Just on that note as well, there's another question. Did you take into account any personalities when you were looking at talk time or and anxiety, Emma's saying as well?
Yes, yeah, I'll just make a note there that the anxiety piece is huge. And if there's a borderline anxiety and then add a communication disorder on top of that, I can imagine anxiety could almost be duplicated there. So I think that's a huge piece to look at. We didn't do any baseline personality tests or questionnaires or anything like that, but I think that's a really great, I think that's a really great thing to consider for future studies.
Hmm. So Linda has said the results are really important, and I find that the talk time of less than a minute per hour is startling, and it suggests that creating communication opportunities through participation-orientated interventions is as important as impairment-based therapy.
Yeah, and I'm gonna just respond back that we were actually shocked when we looked at that number as well. This means that people with aphasia are talking less than a minute in every 60 minutes that they have an opportunity to talk in. The Brandenburg study also, I mean, it was, limited, for the 4 minutes versus the 7 minutes that the healthy people talk in. But, less than a minute is really, was very shocking. What we're hoping, and we haven't looked at the data yet, what we're hoping is that by doing the script training, by having these people in the treatment, and the script training is a treatment that provides them with opportunities and ways to communicate using the islands of words and phrases that they have learned, that hopefully that will help them, to talk more. But it was really interesting, the fact that, the severity of the aphasia was not related to the talk time. Their confidence in communication wasn't related to the amount of talk time. The fact that the fluent aphasics talked more than the non-fluent aphasics was not surprising. We haven't analyzed the quality yet of what they were talking. So, we might find some differences in terms of the quality that might be more important than how much. But yeah, that's a really important comment that Linda made.
Absolutely. So the next question is around the ethical implications. So do you feel like, given those ethical implications being likely predictable, was there enough training for you? Do you feel like there's enough training for your participants about them?
So I can maybe answer that question. I think there were a couple things that came up that may have been predictable for our team, such as, what happens if there's a conversation that I don't want recorded, for example. I found when I was using the devices at home to kind of practice and to see what it felt like, I would find myself maybe much more aware or conscious of what I was saying, knowing it was being recorded, which may open up Pandora's box into real world communication. But I think some of the things were predictable. And one thing we learned as a team, just to be very open and vulnerable about it, was to kind of not make decisions in isolation or in silos, but to really come together as a team and talk about what are our options if these questions come up, and how do we create these situations to explicitly educate people on what their options are. So for example, the person who is doing our informed consent was not the same person doing the training on the devices. So if the person was asked a question about a very technical question about what the device does, that may be best answered by someone doing the training. So I think we learned that it's important for all of our team members to be equally trained in the devices and to have experience using the devices so that we could maybe give those training recommendations or strategies more effectively. And I think we learned a lot from our participants and from their feedback about how we would modify the training were we to do this again. So it was informative for us in the context of this little pilot study, but I think we learned a lot about what we would do differently moving into a future study.
Yeah.
I hope I answered that question.
Yeah, yes, you did. So who asked the question was saying that the ethics committee would have expected a complete plan for the elements of those ethics up front over here. So just going back to the team then, Stevie wants to know, did you have a lived experience advisor or a consumer on the research team?
We did not have a person with aphasia or a care partner on the research team. We did have people who have ethical knowledge who were on the research team, Laura being one of them, and she mentioned, a bioethicist, Alyssa Larkin. So, so we did have that piece of it, but we did not have anybody with lived experience, which was why it was so important for us to get their input later on, because we do realize how important it is, to get that lived experience. I think we didn't know at the beginning what it was going to be like to wear the sensors.
Yes.
So, you know, this was going to be something that was, you know, really very different and very new.
Mm. Mm.
And it started out as such a tiny fraction of this large RCT around script training. It was just a little pilot, and then it's kind of blown up into this really exciting and really interesting sub-study. But I don't think we necessarily expected this to kind of all blossom out of this, again, little piece of a bigger puzzle.
It's a good finding, great result. Like to expand that study in that way. Okay, I'm going to just pivot here a little bit. And Annie is interested in the laryngeal sensor and the application of the device outside of our field. And do you know if it's available outside of your research group?
The developers of these sensors have also used the sensor for many other applications as well. And so it's not commercially available as far as we know, but it is available for research purposes. And John Rogers, who is a very well-known scientist, at Northwestern University, he has a company that you know, is manufacturing all of these sensors. So if they are needed for research purposes, we can certainly put you in touch with John Rogers.
Fantastic, thank you. All right, so we might just finish up the questions there. Let me go to. Oh, am I sharing my screen yet? Share. Share button. Sorry, excuse my technological issues I've got going on here. I'm trying to find my share button. There we go. Got lost in all my windows. So I'd really like to thank Laura and Leora for their wonderful presentation. If you would like to revisit today's seminar or share it with others, the recording will be available on our Aphasia CRE YouTube channel, and it will hopefully be up by Monday. And you can find this recording plus many of our past seminars as well. To stay informed of our work, follow the Aphasia CRE on our blog, Facebook, and on LinkedIn. And by doing so, you'll receive updates on the latest research, participant recruitment opportunities, and a wealth of other resources. So we've still got some fantastic presentations lined up for the rest of 2025. And in July, we are hoping to hear from Dr. Menahemi Falkoff, her presentation, No Gains Left Behind, What SLPs Need to Know About Maintenance in Chronic Aphasia, Who's Most at Risk, What Actually Works, and How You Can Make a Difference. So thank you everyone for joining us, and we look forward to seeing you all soon.
Thanks, everybody.
Thank you.
Thank you.
Bye.
Bye.